upcoming opportunity is an upcoming opportunity focused on multi-cancer detection testing. ACS is launching the Understanding Multi-Cancer Detection Testing ECHO program, and the goal is really to equip multidisciplinary cancer teams and primary care clinicians with a foundational understanding of these emerging tests. So, this ECHO will include understanding how these tests work, interpreting results, and then supporting evidence-based conversations with those patients. So, this is really especially important as these technologies continue to evolve and patients begin asking those questions. We really want to help equip you and your teams on how to answer those questions. So the sessions will be held monthly and very timely. The first one is starting next week on April 28th, and they will run monthly through August 25th at 11 a.m. Eastern. So if you have teams, especially those in primary care or navigation, this could be a very valuable learning opportunity to help build their confidence around this topic. And then the next, you can stay on the slide, but I want to share an initiative focused on rural health and cancer prevention, ACS, along with our National HPV cancer vaccination roundtable. We're partnering with rural healthcare providers to expand access to preventative care, particularly HPV vaccination and cancer screening. So these sessions really provide that practical real world strategy, really focus on peer learning and help teams implement evidence-based interventions. And so those are currently running monthly through June, so a couple of months left to jump onto the opportunity and expand some learning. This is just a really great example of how we're working to reduce disparities and make communities where they are, especially those in those underserved communities. The next slide, please. So lastly, I want to spend a moment on ACS Lion, another acronym which references our Leadership in Oncology Navigation program. This is a standardized training and credentialing program designed to support patient navigators in delivering non-clinical support to patients, caregivers, and families. You might have heard about this before. I know Bridget and I have referenced and presented on it in prior meetings, but we've made several important updates that we wanted to share to really increase access and reduce barriers to it. So, one, the program is now completely free. As you guys all may recall, it was formerly $495 per learner seat. There's no live proctoring anymore, so making it more flexible. And a Spanish version, a Spanish language version is coming very soon, which is really exciting. So, additionally, I just want to highlight that program meets CMS requirements for principal illness navigation reimbursement and also aligns with the National Oncology Navigation Standards of Practice. So, for any of your teams and within your systems that are looking to strengthen or formalize navigation programs, this is a really strong, accessible option, and they can easily enroll just by visiting cancer.org and searching for ACS Lion. And with that, I'll go ahead and toss it over to Bridget.
Thank you so much, Samantha. So the first resource I want to highlight is our Cancer Family History Worksheet from the American Cancer Society. It's a simple tool, but a very powerful one that really helps individuals record cancers in their family, including details like the type of cancer, which relatives were impacted, age of diagnosis, really just to help determine their cancer risk. Users can download and print the PDF just to fill out the information over time and bring it to medical appointments. And I just want to note that having this documented family history can help doctors, genetic counselors really determine personalized cancer prevention and screening strategies, perhaps the need for genetic testing, especially for people who may be at higher risk for cancer. So I can pop this link in the chat so that you can download this. We can go to the next slide. This is just a recent webinar that was hosted by the American Cancer Society and the National Colorectal Cancer Roundtable. It features an engaging discussion focused on community health centers and the current landscape of colorectal cancer, really honing in on one important issue, and that is that colorectal cancer is now the leading cancer killer in adults under 50. So this webinar really helps to translate the data that we have into action by sharing practical tools, resources, and also best practices that health centers can implement to improve screening, early detection, and also patient outcomes. So the link is here with the full recording and also the slide set. And we can go to the last slide. The last slide I have here today is a new report from our CDOC lung cancer screening work group. And this report really aims to provide some clarity around the sources of lung cancer screening data. So we know that lung cancer screening rates in California are relatively low, but that estimate, the exact estimate, can vary significantly depending on which data source you're referencing. And as we know, variations like this can make it challenging to measure progress and also identify where improvements might be needed. So we hope that this brief will serve as a clear reference guide that summarizes the main data sources for lung cancer screening across California and how they compare. I do want to note that we're not ranking data sources. We're simply just highlighting which each data source has to offer. So this report is available on our California Lung Cancer Story Map website. I believe I've mentioned this website in the past, and I'll be sure to pop that link into the chat for easy access. And I believe that's it. And Sheila, I can pass it back to you. I know Ken Wilkerson, our Senior Government Relations Director for ACS Can, is also going to give a great update as well.
Thank you so much, Bridget and Samantha. Now I'll pass it over to Kenneth Wilkerson for ACS Cancer Action Network updates.
Good afternoon, everyone. Kenneth Wilkerson, State Legislative Director for California. I am going to highlight a few bills that American Cancer Society Cancer Action Network is sponsoring and supporting. So these bills that I'll outline work across the full cancer continuum, preventing cancer, detecting it early, and also making sure patients can access care when they need it. One of the bills that we are sponsoring is SB 1309, which is the Stop Lung Cancer Early Act. What that bill does is expands access to lung cancer screening and follow-up testing without cost sharing for high-risk individuals. Many patients never complete the follow-up due to cost barriers, and we all know that lung cancer is the leading cause of cancer death, and this bill helps to remove those barriers and helps to also save lives. Another bill that we are sponsoring is AB 957, our tobacco-free pharmacies bill, which was, excuse me, which was also a bill from last year, but it's continuing this year, thankfully, authored by Assemblymember Ortega. A very simple common sense bill, prohibits retail pharmacies from selling tobacco products. We know tobacco is the #1 cause of preventable cancers. Pharmacies are healthcare providers, not retail outlets for harmful products. You shouldn't be able to buy cancer-causing products in the same place as you go to purchase life-saving medications. So this bill helps to remove those tobacco products from those retail pharmacies. Lastly, a bill that we are supporting is AB 2161, authored by Assemblymember Mia Bonta, which is the Medi-Cal Continuity and Work Requirements Protections Bill. The bill helps to ensure that work and community engagement requirements outlined in HR 1 protects patients with serious health conditions without coverage disruptions. We know when patients are going through different kinds of treatments, it's not as easy to be able to verify their work requirements or community engagement requirements. So this bill helps to reduce that administrative burden. I know I flew through those very, very quickly. And thank you, everyone, for all the welcomes. Very happy to be here. And those are the 3 bills that we are tracking, sponsoring and supporting as of now. Thank you, Sheila.
Thank you so much, Ken, and welcome to CDOC. We appreciate you sharing some Cancer Coalition Action Network updates with our Cancer Center representatives today. So before I move on to Comp Cancer and CDOC updates, do we have any questions for ACS at this time? Just going over the chat really quick and practicing the pause. I don't see any other questions. All right. And then I'd also like to acknowledge Allison, who just joined the call. And I was wondering, Allison, if you'd like to share a few words with our Cancer Center representatives today.
Sure. Hi. Yeah, I did join a little late. Sorry about that, but I am happy to be here. So I'm Allison Herman from UCLA and pleased to be your current CDOC co-chair. And just always really excited to be a part of these calls to see how we can support each other, work towards sharing resources and information. So thank you, Bridget, for always sharing that great information from ACS. And we'll look forward to learning more from our colleagues in San Diego. Thank you.
Thank you so much, Allison. Now I'll call on my colleague Joy Seha to present some of the Comp Cancer updates.
Thanks, Sheila. Our first update is going to be a save the date. So save the date for Monday, September 14th. This is going to be our CDOC biennial member engagement meeting. Biennial meeting that we hold this every 2 years, and it's going to be in person at the Center for Healthy Communities in Los Angeles, also known as the California Endowment. More details are to come. Also, registration is open for the CDOC All Members meeting. It's going to be happening May 27th from 1 to 2:30 p.m. This is an opportunity where we'll share some upcoming educational opportunities and some member-led initiatives and projects, and then some updates for the 2035 State Cancer Plan. Next, the reminder for the CDOC orientation webinar recap. If you're new or just need a refresher on what CDOC is about and our goals and projects, this is an opportunity for you to watch the recording, and I'll be dropping the link in the chat. Next, we invite all members to actively spotlight their work and recognize individuals making exceptional contributions in cancer. So we encourage you to submit your information about your project or any outstanding members using our submission form, which I'll drop in the chat. You can learn more about our member spotlight on our website, and your submission directly supports a key objective in our program's action plan and helps advance our collective cancer control efforts. So it'll also be featured on the CDOC website, listserv, and other CDOC communications. So please take some time to learn more about the spotlight and submit your projects. Last for me is last year CDOC launched a new initiative called the Partner in Focus to spotlight one dedicated coalition member each quarter. The goal is to foster collaboration throughout this community. And so this quarter we highlighted Jennifer Twan from UCLA, and she's an active member in the colorectal cancer screening work group. I will pass it over to Sheila.
Thank you so much, Joyce. So the CEDAW Cancer Surveillance Data Webinar Series provides virtual learning on cancer-related surveillance data sources. CEDAW partners with CCR and others to develop this series, and these webinars offer tools for accessing data for your annual reports or work publications. So our upcoming April 29th session will focus on late-stage diagnosed colorectal cancer and related socio-demographic and screening disparities. A CCR research scientist will demonstrate an interactive web application built using ArcGIS spatial software that maps late-stage screen preventable cancers at county level. So this tool supports jurisdictions in targeting areas for increased screening across several cancer types. And I believe Joyce will be posting the registration link on the chat. And now I'll pass it over to Shante, our program director, to provide some state cancer plan updates.
Good afternoon, everyone. I'm in Sacramento and we're having major thunderstorms. I just lost power, so apologies if I cut out, and one of my team members will take over if that does happen. All right, so I'm going to talk about our state cancer plan, the new state cancer plan 2026 through 2035. It has gone through several layers of review process, and we do have support from the department for this state cancer plan and this whole review. The plan still does need to go through a couple of agencies, DHCS and our Health and Human Services.
Shante,
We lost your audio, Shante.
Shante, can you hear us?
Yes, I can hear you. Is my internet cutting out?
Your audio is back.
Okay. Again, sorry, there's a lot of there's thunderstorms out here and I got kicked off. So basically with the cancer plan, it's still under review. We have full support from the department and it's moving along. All right. So, and along with the cancer plan, once it is published, we have developed these implementation guides that go along with the plan. They're close to finalization. We've been working with a committee that's going to help us. Or that helped us develop these implementation guides as well as disseminate them once they are out. The implementation guides are focused on different target audiences. So you see the one here that's for local health departments. We have one for health insurers, for community-based organizations, and a few other target audiences. So once the cancer plan is cancer plan. Is my audio okay? Can
It got cut off. So yeah, once the state cancer plan is
okay.
published, yeah.
Yes, Sheila, why don't you take over for me? So since I'm having such issues at here.
No worries, Shante. Shante, try to turn off your camera. Maybe that will help with the bandwidth. So yeah, like what Shante said, the plan is still under the CDPH approval, and once approved, it will publish solely online. And when the state cancer plan is approved, your role as cancer centers is to help us disseminate the plan and the implementation guides throughout your networks via email, newsletters, meetings, websites, webinars, and your social media if you have any, so that they can reach the right audience. Next slide. All right. Shante, HPV vaccination.
Can you guys still hear me? I was going to ask you just to finish my slides, Sheila, just so there's not a lot of disruption
No
here.
worries. Yeah,
Okay.
we can hear you. Okay, so for the HPV vaccination roundtable, we just held our April learning collaborative. The next one is on July, and my colleague Joyce will also drop the link on the chat. If you have any topics for this learning collaboratives, we welcome it. So please feel free to send us the topics that you have for the HPV learning collaboratives. The announcement approach training. So this is an evidence-based approach to increasing HPV vaccination, and it is endorsed by the NCI. We hope you learn strategies for recommending HPV vaccination to promote vaccine acceptance and save clinical time. And we are approved for 1 unit of AAFP elective credits, and it's free and it will be held virtually. For the BSIP, or the Breast and Colorectal Cancer Screening Implementation Project, I believe we are at cycle 4, and there were 7 federally qualified health centers that are implementing this project, and their project began on January 2026, and they hold bi-monthly contractor meeting starting April 22nd. And the data is collected through the year with baseline, mid-year annual surveys for the upcoming July-August mid-year cycle. And we will also pause the portal use and conduct data collection through interviews. For the California Health Colorectal Cancer Screening Best Practice Exchange, this has been a project that we've been working with ACS, C4 and CDOC with regards to the health plan team, training the health plan team members with quality improvement, population health, HEDIS, health education, provider relations, and more. So the format will be a monthly virtual long hours sessions, and it will be taking place sometime in June 2026 through May 2027. Our goals are to expand adoption of evidence-based interventions across contracted providers and to increase colorectal cancer screening and follow-up completion among the enrolled and members. We are also developing a sustainability roadmap so that we can integrate it into preventive care and into their routine operations. For the underreported data, this is a project with a Health Access and Disparities Work Group. The Health Access and Disparities Work Group has officially changed their name to Health Access and Disparities. The HAD Work Group had a huge step forward this month in their underrepresented data project, where the community survey completely wrapped up. So they did all the data analysis for it and had an amazing webinar launch that happened last month, I believe, where they talked about and discussed all of the results. The HAD work group is also hoping that this moves forward soon so that they can have all 4 of the surveys wrapped up this year. Next slide, please. So as a quick recap of the March 12th webinar, the webinar went extremely well with about 168 people registered and 75 attending live. Special thanks to Dr. Shannon Kozlovich for leading this effort. The presentation highlighted key findings from Underrepresented Data Project Community Survey, a collaborative effort with the California LGBTQ Health and Human Services Network. It also shared insights on how healthcare data collection can be more inclusive and affirming. Panel discussion also focused on advancing dignity, agency, and equity across the healthcare systems. And the community organizations team reviewed the survey results, and then their advisory board drafted 5 clearly worded best practices now being developed into a report. So if you missed the webinar, I believe Joyce will be adding the YouTube recording link on the chat as well. Moving on to our survivorship work group, the psychosocial support project is still currently being implemented by the Cancer Support Community San Francisco. We're hoping to continue some projects in the next fiscal year, and we'll have details much later. The Cancer Support Project brings support to cancer caregivers across California through a partnership with Triage Cancer. So the goal of the project is to provide caregiver education, practical tools, and individualized navigation services statewide. Available resources include free webinars, practical guides, bright boxes, and one-on-one legal and financial navigation for caregivers. So the CDOC CHW Guidance Initiative uses a policy, systems, and environmental approach to develop adaptable guidance for organizations, CHWs, patient navigators, and promotores. So the initiative convenes a multi-sector advisory committee, including cancer centers, a couple cancer centers, representatives, CHW-focused CBOs, payers. We also have ACS, Indian Health Services, and then CHW training developers such as the ACS Lion and a member from the GW Cancer and other partners to help inform and reform this CDOC CHW guidance. So we met the advisory committee for the first time on April 6th, and we will continue meeting through July to complete the review. So these meetings will help shape the final CDOC CHW guidance package and prepare cancer centers for their main action item, which is the upcoming sign-on process. We also began outreach with HCI, or Healthcare Access and Information, and DHTS to support future statewide dissemination of this guidance. A core goal is strengthening partnerships to expand their training, alignment, and implementation of CHW cancer-related programming statewide. And the guidance focuses on 3 priority areas. We have cancer prevention and screening early detection module, community research and clinical trial engagement module, cancer survivorship and supportive care module. So once the advisory committee completes review, we will move into a formal cancer center sign-on process. And after the sign-on, the guidance will be submitted for departmental approval. And upon approval, CDOC will share the final guidance with HCI, DHCS for statewide posting and dissemination. We're also exploring potential partnerships with health systems that employ CHWs to help support future adoption of the guidance within their organizational plans. All right. In today's presentation, we can move to the next slide, Joyce. We have the pleasure of hearing from Moores Cancer Center at UC San Diego. Margaux serves as the Community Outreach and Engagement Manager at Moores Cancer Center at UC San Diego Health, where she oversees all aspects of COE activity implementation and has served with this team for nearly 6 years. She has over 14 years of experience working in healthcare and life sciences, spanning biotechnology, public health, and impact philanthropy. Margot holds a Master in Public Health with a concentration in health behavior and pursues a career in public health fueled by the belief that improving health and individual agency is a viable path to a more just society. Please welcome Margaux Stack-Babich.
Thank you so much, Sheila, and all the team for having me today. Good to see everybody. Great to see familiar faces and some new faces. I am presenting this information on behalf of my leadership today, and there's individuals who are worked a lot more closely with the analysis of this work. And so I just want to say up front, if you have any specific questions about how we made some of the decisions or did the analysis that I might not be able to answer, I'm happy to pass those questions along to my colleagues. So hopefully you can get what you need if you're working on something similar, or you have guidance and feedback for us. So just wanted to say that up front. But I will share my slides right now. And just let me know if you can see everything okay.
I can see your PowerPoint.
Okay, great. I think it's taking a second to go full screen.
Sounds good.
Okay, oh, there we go. Sorry, stuck. Okay. Can you hear me okay? See it okay?
Yes.
Okay, great. Okay, well, thank you again for the opportunity to talk about this work. This was a collaboration. Some of you may know this, but our cancer center down here at UC San Diego is a consortium cancer center between ourselves, San Diego State University, and the La Jolla Institute for Immunology. So between the three institutions, we all work together, and each of the individuals of these institutions can be members of our cancer center, which makes a really great combination of skill sets and individuals who compose this consortium. And so this particular project was a close collaboration between the Institute for Public Health at San Diego State University and our team at Morris Cancer Center. So just wanted to make sure credit where credit is due. This was a collaborative the whole way through. And what I want to share with you today are the findings from a community health needs assessment focused on our LGBTQIA plus community here in San Diego, which took place between 2024 and 2025. So the purpose for this needs assessment really came from, which I think maybe goes without saying for this group, but just to make sure I underscore the point, the lack of clear characterized data for this community when healthcare experiences often are not documenting well the folks who are coming in to get their care, really having a deeper understanding of the demographic realities of our patients here in San Diego and across the state and across the country. We really have a lot of data vacuums and invisibility of this community, and which is really the very, very first step to taking the necessary steps to make sure that we can make health equity possible for everybody here in San Diego and beyond. And so in an effort to illuminate the realities of the lives of our community members who identify as part of this community, really, again, the spirit of this needs assessment was to start documenting and understanding who our community is, what are their healthcare knowledge, beliefs, access, and risk factors, so that when we then have this data, we can be as strategic as possible in the delivery of care, in education and outreach, and in partnered activity between ourselves and our community partners and organizations. So again, this is very foundational to just really understanding the needs and realities of our community members and having that data. So we set out in 2024 between ourselves and IPH to conduct this needs assessment. And really, we wanted to take that additional step to look more closely around cancer screening, cancer diagnosis, and healthcare experiences. There are other needs assessments that are done by community partners here that are more general, that don't have as many specific questions as this needs assessment did, that really were dialing into cancer screening, cancer knowledge, cancer risk factors, and diagnosis. And so that's where we felt there was opportunity to add to some of the efforts that are ongoing here in our region, and also I know across the state. So the goals of this needs assessment were, like I said, really to inform how we can improve cancer screening rates, improve prevention, and improve healthcare experiences for our LGBTQIA plus community here in San Diego. And again, hopefully that what we learned and what we have found so far, that where there's applicability beyond San Diego, across the state and across the country too. Critical for our approach, and I know from so many of you too, is that this data went back to the community, and that the community members and leaders are really part of driving the next steps of this data and the potential actions, interventions that are becoming more clear as we continue to parse through the data and the results. And really, we wanted to provide not just the data back to the community, but also to researchers and healthcare providers, practitioners, so that they're more informed in the work that they do in serving this community. And so there's multiple audiences, of course, for the results. What's, I think, really a point of pride for so many of the folks that worked on this study and the analysis is that we really were partnered all the way through with community members and leaders, folks who do work in healthcare and folks who don't, who are just consumers of healthcare and who live in San Diego and have experiences that are really critical to everything from how we ask the questions, how we made categories, how we came up with definitions for certain orientations, questions, how the analysis would be done. We really had the benefit and the privilege of working with community members all the way through. But really, of course, in developing the instrument, their feedback was essential. So across all of these domains, we really tried to be as comprehensive as we could be in surveying the community. And so, of course, demographic data, but also health insurance, healthcare utilization experiences, knowledge about cancer screening, knowledge about screening up to date, how timely folks were with their screenings, if they knew they needed them, how their interactions were with physicians. You can see that we spotlighted a few different disease areas where there is the benefit of some more data around HPV vaccination, HPV-related cancers, and liver cancer. So we had some specific questions to make sure we asked the community in the survey, skin cancer as well. Also cancer diagnoses information. So we really were comprehensive in asking these questions and making sure that if we had the opportunity to engage with community members and could pay them for their time, that we were really being comprehensive in the data that we gathered. So the eligibility for participation was that individuals identified as a member of the LGBTQI+ community, they were adults aged 18 or over, and that they resided or received primary health care in San Diego County. The methods for collection included both online, paper surveys at events, and phone interview options for folks who might be more comfortable doing this. And so we tried to provide as many different formats for folks as possible and was feasible for them, depending on what their comfort level was with doing the survey in person or in other formats. We had the survey available in English and in Spanish, and for this survey, there was a $15 gift card incentive to complete. And so, and I can talk a little bit about this in a second, more on actually how the surveys were collected and done. Okay. So we actually had over 600 individuals take the survey, but in the sort of preliminary analysis to see who really adhered to the eligibility criteria, a few folks were, either they were duplicate answers or were not not living in San Diego or not getting their primary care in San Diego. And so when it was all analyzed and cleared, 516 surveys were decided to be the complete data set from community members here getting their care in San Diego. So we felt really, really pleased to see that number. And you'll see in just a moment, kind of who took that survey and their other intersecting identities. Just to list here, we were so grateful and pleased to work with so many incredible community partners health systems along the way. And you can see it really took a village and so many people involved in getting the survey out to the community and making sure that because there was a paid incentive, we were really careful about not just spamming this anywhere and everywhere so that we would have some integrity to the data, but working really closely with community partners, healthcare organizations serving this community, and going to specific events across San Diego County where we know community are sort of safe places, or gathering spaces, are trusted spaces. And so between all of these different outreach efforts, we got to this 516 survey number. So I hope that helps to fill in kind of getting to this final number. So as well as having partners involved in the origination of the survey, the analysis, we also worked closely with community partners and advisors on doing the analysis and conducting the analysis. So who to include and how to characterize, how to cross-tabulate different identities and circumstances in folks' lives, what were priorities for community to hear about, how would we make definitions, how to present the results. There was so much data that we have a very long report, which I think if I can get permission from our PIs, that I would be able to probably share that directly by email if anyone is interested to see. And you'll see, if you see this data report, that it is extremely comprehensive. And so we were sort of, it's a blessing and a curse to have so much data. So what is really the most critical? What is the most critical information to communicate back to both community members who can benefit from the learning and the education, and also to healthcare providers and practitioners who also can be benefiting from these findings? And so there's a lot of discussion around that as well, and it's ongoing, I should say. How should we talk about these reports and the times that we're in, and how and what settings should we talk about the partners that were involved? I shared the partner organizations today in this setting, but we've also been in other settings where we haven't gone through quite as comprehensively the list of partners, because we want to protect the work that is being done right now. So, and how should results be presented or shared? So there were a lot of really critical questions that were discussed among partners, and they continue to be discussed among partners as well. But I just wanted to assure everybody that those conversations, as soon as the data was collected and going through preliminary analysis, were being had as well. So taking a look at the data itself, I'm just going to minimize my the gallery here so I can see a little better. So as far as self-reported demographic characteristics, you can see along these different domains, along race and ethnicity, by age and by sexual orientation, you can see some differences and some trends. We were really pleased to see very good representation from our Hispanic and Latina community down here in San Diego. About 48% of folks who took the survey identified as part of this ethnic group. And then 29% identified as white, 9% identified as Black or African American, 7% as Asian, and 3% American Indian, Alaska Native, and then 4% all others. And you can see in some of the footnotes the discussion around all others and more than one race, et cetera. For our age group, we were probably a little overrepresented to our younger cohorts, and then some good representation for our more senior cohorts, and a little less representation kind of in the early millennial Gen X age group in the middle. And then on the right, on sexual orientation, we had the largest participation from our gay and homosexual community here in San Diego, and then pretty even participation from our lesbian and bisexual communities, and then somewhat less so for pansexual, queer, and all other communities. And I'll move right along here. So these are two different areas just to underscore here. So on the larger graph here, this was part of the discussion on how to talk about the data, what terminology to use, and how to parse through answers of, submitted answers in the self-described section, and where they may actually fit well with some of the categories or designations that had been prescriptively suggested. And so the team worked hard to think of, make sure that there was multiple ways of representing this data so it may be as comprehensive as possible. So you can see on the left and the right some grouping and consolidation along these different lines and delineation. So on the right hand side, you can see 46% of those who took the survey identified as cisgender men, 30% as cisgender women, 9% gender diverse female at birth, 7% gender diverse male at birth, 5% transgender women or trans femme, 4% transgender man or trans masculine. So again, a really, I don't know if I say overrepresentation, but a substantial section of the cohort were cisgender men. So we had hoped, I think I can comment that we'd hope to sort of have that a little bit more representation of our trans community here in San Diego, but we were happy to have the participation that we did, and so it's something to consider for the future to have more robust power when doing analysis and having a larger N. For the top right, we always are trying to track, where our constituents are coming from and taking these surveys. So San Diego is broken up loosely by the county into our central, north coastal, east, north inland, and south regions. And so overwhelmingly, our respondents came from 45% came from the central region. It's also one of the most densely populated parts of San Diego. So there's a lot of sense to that response. And then fairly even representation across the rest of our sub-regional areas in San Diego. So getting into the cancer screening data itself. So you can see, I just want to point out quickly, even though there's 516 respondents, the team worked to remove people who weren't eligible for certain screenings when doing the analysis. So the N for each of these individual responses is underneath the bar chart. So it varies from 200 or almost 200 down to 39. So those determinations were made by looking at the screening guidelines for each of these cancers and then modifying the pool accordingly. So what's, I think, an overall observation to make for each of these, whether it's a small cohort, a small N or a larger N, is that there is discrepancy between having ever been screened for these cancers and being up to date with these cancers. And then that discrepancy varies across different cancer types. And so but for our colorectal, for folks who are eligible for colorectal cancer screening and for cervical cancer screening, it was about a 6% difference for those groups. I think that was the smallest difference. For mammography, it was about a 7% difference for ever having been screened and being up to date. And then there were bigger gaps slightly for anal cancer screening or anal pap screening, for prostate cancer PSA testing, prostate cancer screening, and for lung cancer screening. And actually, lung cancer screening may be a grain of salt with this data point, as it was the smallest N of all these groups, 39 individuals, but the most substantial delta between ever having been screened and being up to date with that screening. So in the spirit of what we heard at the beginning of the meeting about the importance of improving lung cancer screening in California, one more note to underscore there as well. And I'll just move quickly along. Oops. And then just to spotlight here, and I think this may be true for my other colleagues on the call who are working in California, but liver cancer here in San Diego is one of our priorities as determined by the Cancer Center. You see really a disproportionate burden versus US trends in incidence and mortality. And we do see a really disproportionate burden for diagnosis in our Hispanic community and our Asian Pacific Islander community here in San Diego too. And so because there's so many related risk factors for liver cancer, we wanted to dig into those questions a little bit more. And so these are larger N's. Some of them are more, about vaccination. Have you ever discussed hepatitis B testing or vaccination? So a little more than half of the group had that discussion. Slightly less than half had discussed alcohol use and its relationship to liver cancer. About the same amount of folks had discussed hepatitis C testing or treatment. Only 17% had ever discussed liver cancer at all. and 14% had been told that they are at risk for liver disease. This one sticks with me because we work with our colleagues who treat liver cancer patients at the Cancer Center. We have heard anecdotally how it can be fairly typical or common for patients to show up in the ER without having any idea that they have liver disease, let alone liver cancer. And so there's real urgency in our eyes on better education around knowing what those risk factors are, reducing risk, and identifying disease in its earlier stages before a patient has advanced disease and or at risk for cancer. 27% of the 510 respondents had reported ever having a medical professional look over their whole body to screen for skin cancer. And I think others on the call see this too in their work, but getting into a dermatologist or for primary care skin cancer screening check is something I think can be a barrier for many of our patients and community members. So that was one we wanted to note as well. These two on the left-hand side, just focusing on the cancer screening, knowing what you need and where to get that screening. And again, this is working still with most of our whole cohort of 516 respondents. So 53% of 510 respondents said they know where to get cancer screening tests. I think that's an important one to underscore. That was really only a slightly over more than half of the individuals did know where to get cancer screening tests done. Again, it's slightly over half of the respondents of 511 respondents that they would like to know, they would like more information about cancer screening tests. And then a smaller percent of 40% knew where to get cancer screening tests from a provider who was knowledgeable about LGBTQIA plus health. And I think when we get into some more of the specifics on knowing what organs you need to have screened for different cancers, and knowing if your provider is aware about your identity or sexual behaviors and what preventive measures or other realities about your life that they may or may not know. There is, another really important factor to have understood in your care and making sure that you're getting the comprehensive care you need to prevent cancer in your life. And then on the right-hand side, some more specific questions about HPV. And so had you ever heard of HPV? That was good. 84% had ever heard of HPV of 512 people. A little bit less, 73% had ever heard of Gardasil, the HPV vaccine that is used in the US. 68%, a little bit less than that, knew that HPV could cause cancer in persons of any gender. And then 39% had ever been vaccinated for HPV, at least one dose out of the 508 people surveyed. And so that I think there was some slight modification on folks who might not have been eligible ever in the time that the vaccine was available. But this is something that's still most of the respondents who took the survey that were asked that question, and only 39% had ever been vaccinated for that. And as you saw from the beginning, we did have a large representation of the younger adults in San Diego. So it's something important to remember. This slide really was breaking down what reasons individuals had for not being screened regularly. So you can see we have the analysis by cancer type to see where there may be differences and similarities between these different procedures. You can also see the variability in how many people were eligible for those tests and then answered this question. And then those were added up to the 254 respondents. And so if I just go by all, because I want to keep my eye on the time, and please pull the plug on me if if you need to. But on the right-hand side, just going by all, 56% of respondents across these different cancer types said they did not know regular screening was needed. So it's a really, 56% of 254 people. 16% were told that they do not or no longer need to get screened for cancer. So that would be interesting to pick apart a little bit more, whether that is that was accurate advice from a medical professional who, if these were, especially for our older patients, if they were no longer, recommended for that screening, or maybe a bad communication about what was necessary. 8% did not want to discuss with a medical provider. And then we don't have the aggregate for the last two questions, but you can see 38% for anal cancer, so they did not know about it. So, you can take a moment to just check out any differences and similarities across these different cancer types. I think especially for the cancers where, I should say, for cervical, for breast, and for colorectal, where those screenings are, there's more infrastructure to support those screenings happening across more of our health systems and health centers. So we hope that those are the ones that are being, more likely to be recommended routinely. They're more baked into our health delivery processes. So it is concerning to see that in those cancers, especially, that, there is 62%, so they didn't know regular screening was needed. And then 58% for colorectal, and then for breast, at least for breast, you can see only 6% didn't know that regular screening was needed. So there is so much here, and I don't want to bamboozle you with so much data, but it's something I should also underscore. If there's anything you'd like to do a deeper dive with our team and walk through this in more depth, we'd be totally happy to do that. There is so much here to pick apart and to understand. So, but you can see, I think, overwhelmingly, the point really of this slide is that there's still a need to educate and make sure communication between providers and patients is clear and understandable, and that the realities of the patients' lives are known to the extent that patients feel comfortable to their providers too, to make sure that they are getting the right recommendations for their health. So the dissemination piece. So, something that I can pop in the chat after this and upload some of the PDFs that our team has been working on and updating and working with partners to create are actually at the bottom here for the community members. So our team has been working to distill down. I think that's been some of the hardest part, now that we have the data and we have the comprehensive report, is trying to really boil down and pull out what are the really key findings, critical pieces of information to relay. And as even briefly in this presentation, you can see there are so many areas. There could be so many specific tailored reports, summaries, presentations to to our seniors, to our Black and LGBTQIA plus community members, to our Hispanic LGBTQIA plus community members, just on breast cancer, just on cervical cancer. So there's so much data here, and there's so much need to communicate this, and again, to multiple audiences. So as you can see, across all of these domains, we have medical professionals, researchers, community organizations, and community members. I'm so pleased that we were just our team was at ASPO, the American Society for Preventive Oncology, that met in Denver just a week and a half ago, 2 weeks ago, and presented this data there. So, our team is working to get this information out to the research community generally, as well as our colleagues here in San Diego who are working in this space. So we're working to educate our researchers about this, working to report back out to community organizations. We have some upcoming presentations with our LGBT Center, which is a huge institution here in San Diego, working to link up and do more presentations with other organizations that serve the community here in the county, and educating our community members directly. So between presentations that we can do in safe spaces and trusted spaces, and also create more collateral infographics, one-pager summaries that are easy to read and understand. And so I think we're in the space of trying to go to the next level of digestible, clear, fun, and compelling, interesting graphics and messaging that are actionable and easy to understand for community members, and then be more tailored so that as we look at these data sets and see where intersectionality creates more risk, less risk, different risks, that those are being reflected back to the communities that are experiencing these risks. And I will say medical professionals is another whole area where we are working to create collateral education with some different answers and responses that we didn't touch on yet in this presentation. I am trying to be mindful of time. I do have a couple of slides on what's the sort of more qualitative findings of this survey when folks were asked about their healthcare experiences. So if there's time to quickly show that, it is a little more dense. So I just want to make sure I don't run over my time. But I can maybe pop that up very quickly. But suffice it to say, we have, as you know, so many audiences that need to be made aware of this data. There's a lot of work still to create, distill this data down, make it understandable, make it digestible, make it relevant to community members, to partners, to healthcare teams, systems, and researchers, so that it's known and it's used and it's actionable. So we are really at a great moment for having this data, having gotten kind of preliminary collateral created, having our first presentations to researchers. Pride is coming up here in San Diego. We observe Pride in July. We have a big festival in July. And so we're really working now to think about how do we take some of the data that we have and really make great collateral for July, so that we are and do kind of promotion between now and July, so that what we have learned and what people have shared with us is being used and fed back. So I can pause there. Sheila, I don't know if I have like another minute or something quickly to pull up the.
Yes. Go
Okay,
ahead, Margie.
I'll
Yes.
go very quickly to this slide just because I wanted to make sure everybody was aware this kind of information was also learned about in the survey. But we asked respondents, what are the most important things medical professionals need to know to be welcoming and respectful of the realities of our LGBTQIA plus community members' lives and what is important to them. So we tried to make, kind of condense these into categories here. So and I think what's sort of important to underscore is that many of these things are what I think we really hope for across the board, right? Respect from medical providers for names, pronouns, identities. Not to make assumptions. Not to assume that somebody has all the information they need to know before addressing you. The importance of pronouns, being conscious of racial and ethnic identities and the intersection of those identities, awareness of types of sex that doctors want to know more about, what kind of behaviors community members are participating in, so that they can make specific recommendations around that. Not to gender body parts or organs, and using inclusive language. Again, I know our colleagues presented, just recently on, I'm sure there was a lot more discussion on this, and I'm so sorry I missed it. But some of the really clear needs that were stated affirmatively, and you can see there in quotes, these were specific responses that were made by our community members, and you can see clearly, just be kind and respectful. I think there's a lot that can be engendered by just being kind and respectful as people are learning and becoming more competent in their care, but really be coming from a place of kindness and compassion. And I think, let's see, I made this maybe a little too much more information than I have time to do, but I'll pause there just in case there's any questions or you might have any questions about what I shared so far.
Thanks, Margaux. Just want to highlight Stoney's comment on the chat. San Diego County's Colorectal Cancer Roundtable that has been held annually for 12 years to increase CRC screening and FQHCs is reflected in your data that you presented. The roundtable is led by Moores Cancer Center. Thanks, Stoney.
Thanks, Stoney. Absolutely. Yes, we're really fortunate that down here in San Diego, several of our federally qualified health centers really are leading the charge, I think, in setting the standard for really, really inclusive, competent, compassionate care for our LGBTQIA plus community. And I think many of our larger health systems have lessons to learn from them. So Family Health Centers, San Isidro, Vista Community Clinic really are setting a bar, I think, for how to care for patients comprehensively and respectfully. So we were really lucky to have their partnership through this survey, and keep learning from them and keep learning from each other.
Yes, thank you so much, Margot, for such an informative presentation and for giving us an inside look at the lessons learned from your assessment work. I've been seeing awesome presentation from the chat, so that's great. All right. I don't see any other question. And then Margot, can they reach you out directly if they have any follow-up questions with regards to your presentation?
Yes, absolutely. I'll put my email in the chat, and I would love for you to reach out to me about this because I think I feel like I'm just scratching the surface from, how much data there really is and how much analysis can be done on the data. And so I know so many of you are really experts in the space and really leading the way. So we'd love your comments, your thoughts, or if you have, you just want to collaborate further. So please reach out.
Thank you, Margot. All right, I guess we can bring up the slides. Thank you, Joyce. All right, so I'll continue on with some of the Cancer Center updates. So last January, we reached out to all of you to request updated roster information. Thank you to all of those who have shared updated roster information. So these updates will just help us ensure that we have the right contact for communication, meetings, and resource sharing. And then along with that roster request, we share the CDOC Cancer Center's collaborative engagement framework. So the framework outlines the purpose of the collaborative, any expectations for your participation at these meetings, and your support and the support that we provide to all the cancer centers. So our hope is that having the framework really encourage continued participation in these quarterly meetings and shared activities. And the framework also positions us for the upcoming strategic priorities, including the California Cancer Resource Hub. So for the California Cancer Resource Hub, we presented this topic in January meeting, but we want to keep it here as a reminder in case any cancer centers are still considering taking on the platform financially or assuming ownership. So I'm going to just give you a brief overview of this slide. So the California Cancer Resource Hub, or CCRH, was originally developed using additional funds to compile survivorship resources. Progress stalled due to IT restrictions and contract challenges within CDPH, which prevented the completion and further development of the resource hub. So the platform itself is built, but it needs an organization to take over ongoing management and updates. So it was noted that even if cancer centers take it on, the responsibility must really be assigned to a specific individual or hosting cancer center. So an idea was to structure the hub according to COC, or Commission on Cancer, standards. And doing so would help cancer centers meet accreditation requirements by organizing the resources in a way that aligns with those standards. So the hub could be tailored specifically for cancer centers, serving as a central location for resources they need to meet the standards and requirements, like I said. And this would also reduce the duplication efforts and hopefully ensure that the hub stays focused on cancer center needs. So we're still seeking a cancer center host that is interested in potentially hosting and maintaining the resource hub. And we'll most likely continue presenting this opportunity to identify a cancer center that is willing to take on ownership and support ongoing efforts and help bring the platform back to life. All right. As a quick reminder, the Cancer Centers Collaborative was established under the 2021-2025 State Cancer Plan as a statewide network to connect all the cancer centers, share resources, and elevate best practices throughout California. So the collaborative directly supports the state cancer plans focused on collaboration, data sharing, multidisciplinary care, community engagement, and reducing disparities. Now, as we transition to the new state cancer plan, the first 10-year state cancer plan, participation from all cancer centers remain highly relevant and essential. This group has been meeting since 2022 and sharing opportunities, but has not yet launched a joint project. But moving forward, gathering your strategic plans will help identify alignment and collaboration opportunities. I'll pass it over to Shante to share more information regarding strategic plan requests from all of you cancer centers.
Thank you, Sheila. I really don't have too much to add, excuse me, other than what Sheila just shared. We will be formally requesting strategic plans for those who want to submit these and help us engage in a strategic planning process for this collaborative. And as Sheila mentioned, we've been meeting for a long time. We have a lot of resources and expertise in this group, and we're just looking to really identify something that can help us move our objectives forward in the state cancer plan. So again, we'll have more on this process in the coming weeks.
Thanks, Shante. And then before we move to the next slide, Joyce, I just wanted to open and give the opportunity for other cancer centers to share any upcoming events and resources. I know Margaux has a cervical cancer quality improvement learning collaborative on July 9th, and she also dropped the registration link on the chat. So this is the time for anyone to share any resources or announcements from your cancer centers that you'd like to share in this space. And Bridget, thank you for sharing all the ACS links on the chat. Yes, we'd love to receive it on email, Margaux. Thank you so much. We'll share it with our follow-up email with the cancer centers. Okay. Oh, go ahead, Stony.
Yeah, just a quick question. Do you have time for questions? This would be one for Kenneth if he's still on the three bills that he's working with. But I'm very curious about the lung cancer screening, how they're approaching the fact that it goes beyond the U.S. Preventive Services Task Force definition of screening. In other words, the requirements for the tests after the screening are not considered part of the screening process. They're the diagnostic process for the findings on screening. And also just a little update on the other, are they through the committees? Have any of them passed through the Assembly or the Senate? And where are we on those three bills?
Hi, Daniel. Do you mind repeating your first question, please? I didn't catch all of it.
Okay, it's on the lung cancers bill. It's to remove cost sharing, and I assume that's for the tests after the screening test. So that goes beyond the Affordable Care Act, which only gets rid of cost sharing for the screening tests. The required diagnostic tests after a nodule is found on the lungs, and it can be a different test depending on the size of the nodule and so on. How did you get around the fact that that's not part of the Affordable Care Act and the cost would have to absorbed by the state to remove that cost sharing?
Yeah, Daniel, I'll have to get back to you on that specific question. It's a
Okay.
very detailed response, and I don't know if we have enough time for that, but I can reach out to you directly for that
Sure.
information. And then for your second question regarding where the bills are, so AB 2161, which is the work requirements bill, has passed out of Health Committee. Tomorrow, actually, SB 1309, the lung cancer bill, is getting heard tomorrow in the Health Committee. We've already, based on my internal vote count and discussions, that'll get out of Health Committee. Fingers crossed if nothing changes in the next 24 hours. AB 957 was a bill from last year. It went through the Assembly, through the whole process, got the votes it needed. Now it's on the Senate side, which will be picked back up in June in Senate Business and Professions. So a lot of the legislators are not focusing on 2-year bills right now. A lot of the priority bills are the ones that have been introduced this session. But we're hopeful with a new chair in Senate Business and Professions that we're able to get that one out of committee when the time comes in June as well.
Okay, thank you. Yeah, the reason I asked that first question, when we got the cost sharing out of the Gibson bill that was passed a few years back to remove cost sharing in colorectal cancer screening, we had to get it to where the tests after a fecal test or a non-colonoscopic test were considered screening tests. So the screening was a process. The screening for colorectal cancer screening was a series of screening tests. So it was a screening test, not a diagnostic test. And then that way the governor signed it. It was vetoed the first time by Governor Brown because it went beyond the Affordable Care Act.
Thanks for that information,
And
Daniel.
so
If
if
you
you
don't mind
figured
putting
out a
your
way to
email,
get her, yeah,
I think I know the answer to your question, and we have. But if you can just shoot your email in the comments, I'll email you directly because we're still in
okay,
discussions about amendments and things like that. And one of them is actually surrounded around that. So if you can drop your email in the chat, I'm happy to reach out
okay.
separately.
Thank you so much, Ken and Stony. All right. Do we have other questions or comments? All right. I think we could move on to our last slide choice. Thank you, everyone. As a quick reminder, we'll maintain this quarterly format for our collaborative meetings. All the 2026 dates are shown on your screen. The Cancer Center hosts are identified alphabetically with the next host, which is the Stanford Cancer Institute. But if you would like to present a project, please email me or anyone at CDOC. Also, please complete a short evaluation, which has also been dropped in the chat. We will email the slide deck and any follow-ups and the meeting recording as soon as they are ready. Thank you once again for sharing your valuable time with us, and we look forward to your continuous collaboration with all of you. Thanks, everyone.